Welcome to the Health Daily Show, your go-to where leaders, founders, investors share insights on growth, innovation, business building. I'm Chitra Navat. Joining us today is Marty Bonick, CEO, Ardent Health Services. Marty, welcome. Thank you for joining us.
Thank you, Chitra. Glad to be here with you.
Marty, Ardent Health Services owns and operates 30 hospitals in 6 states, more than $5 billion in revenue. Share with us the scope, scale of Ardent.
Sure. Ardent Health Services really started as a hospital company, but today we've grown into much more than that. Healthcare happens more and more outside the four walls of the hospital, and so while we have 30 hospitals in 8 markets across 6 states, primarily in the central United States, we also have over 200 sites of care in the clinic and ambulatory environment. We've got 1,400 physicians that we're either employed or aligned with through contractual joint ventures, and we have 24,000 team members across our company, ranging from New Jersey to Idaho, Texas, Oklahoma, Kansas, and New Mexico.
Given this diversity, share with us what's unique and challenging about your patient population and these pockets, these niches that you serve.
So I think every market has some similarities, but in general, for Ardent, our niche has been to focus on the smaller urban markets, where we can come in and have a foothold with a major operation and then have surrounding satellite hospitals, clinics, outpatient infrastructure. And so we're able to care for all patients regardless of where they come from. We are in a mix and a variety, as I talked about, of different types of states, some that have expanded Medicaid, some that haven't, some that have different political ideologies, Texas versus New Jersey. You can leave the rest to imagination there. But we're serving all kinds of people, and our employee base makes up the diversity that reflects the communities we're serving. So I'd say in a lot of respects that we have the same mission and goal in terms of treating everybody that comes through our doors. But how we do that varies upon the states that we're in, the different payer landscapes that we're dealing with, and the size of the markets, again, those smaller urban footprints.
So just on that, the different payer landscapes, the different strata, if you will, what are the implications operationally and on the economic side?
Yeah, operationally, I think the entire industry is suffering from a severe acute workforce challenge. That's not a surprise. That's not unique to Ardent. I think that's pretty universal in healthcare these days. But we're in communities where we have to make sure that we can take care of all the patients that are coming to us, regardless if that's for acute care, for outpatient ambulatory care clinics. And so we're dealing with those challenges in different ways, and we'll talk about that some more, I'm sure. But what we do, how we do it is very similar to some of the challenges that you're seeing in other markets.
And on the economic side, what are the implications?
Yeah, so I would say that we are more so in middle America by and large. We got a little exposure in New Jersey, but by and large, the payer landscape has been more traditional. They've not been as innovative. And so we are still largely in a fee-for-service world, but trying to forge our way into that value base. And so we're living in that fee-for-service environment with steps into the value-based world economically.
So on that front of that continuum, share with us, what is that plan or that transition process for you going from fee-for-service, fee-for-value to value-based care?
Yeah. So every contract that we have, I'd say, is moving in a direction. If it's not, we're not taking full risk in most any instance, but we are having value-based components. So we have to prove the outcomes for the care that we're delivering are where they should be in order to get incentive payments reimbursed. So a lot of our fee-for-service revenue is tied to value-based metrics. So we're embracing this. I think that that's the way healthcare should evolve, that we should be accountable for the outcomes and the actions in which the care for what we're providing. But we are embracing that because we know that that is the future. And if we can do that better than our competitors, then we believe that we'll be able to move market share, and that we can have accessibility, we can have affordability, and we can have good outcomes. And that is really the triple aim that we're all out for. And value-based is a way of pursuing that. Now, we're not pursuing risk for risk's sake. We're not pursuing value for value's sake. We're doing it because it's the right thing to do. But we believe that ultimately, while we're in this hybrid universe of fee-for-service and moving towards fee-for-value, that we can capture more market share, which in a fee-for-service world definitely benefits us.
Can you give us an example to bring this to life for us? Because especially when you're talking about fee-for-service tied to value-based metrics.
Yeah.
Example, Bring it to life.
Yeah, so this goes back to us starting as a hospital company, but really trying to be much more than that. And so as we expand outside the four walls of a hospital, I want to have all the care that you receive throughout your journey. And in the acute care hospital business, we know that patients exist for more than their 4.6 day length of stay that they're with us. A lot of times patients have chronic conditions, and you had a condition that got out of control. You came to a hospital and we cared for you, we stabilized that, but likely you still went home and had a chronic medical condition. What we're really focusing on is staying close to the consumer, staying close to the patient throughout that life cycle, and not just for the 4.5 days that they're with us as an inpatient. And so we're really trying to capture that continuum pre, during, and post that acute episode, and beyond the facility side. As consumers, we're all consumers in our everyday lives. How we interact with the patient, from a digital interaction, from a follow-up perspective, and knowing the patient better than they know it themselves in terms of the care that they need, trying to stay engaged with them and finding new sources of revenue to compete with in the marketplace.
So exactly on that point, how then do you manage the transition from fee-for-service to value-based care revenue and the cannibalization that happens on the fee-for-service side?
Well, two things come to mind. One, this staffing shortage that we're in is the most profound I've seen in my 25 plus years of doing this. And so the reality is we have a staffing shortage right now that is limiting our capacity. So the right thing to do for patients is to keep them out of the hospital. And we can't take every patient into the hospital right now. So what we are trying to do is to work with our payers and find avenues where by keeping chronically ill patients out of the hospital, that we can work with them on an arrangement where we can get paid to keep them well, so we can make room for the patients that truly need to be inpatient, whether that's a procedural patient, a surgical patient, a cardiac, orthopedics, those types of things, spine surgery. We want to make sure we have room. So we believe by expanding the continuum and focusing on value beyond the four walls of the hospital, that we can treat people, whether that's virtually through telehealth, through remote patient monitoring, chronic care conditions management, social determinants of health, and ultimately back into our clinic system. We can keep people well and out of the hospital for only those that have to be there, and work with our payers to get incentivized to keep people in that situation.
A little bit more then on the strategy here of the specifics in terms of improving the productivity of your relationships with payers. Mm-hmm. Like over the next couple of years, what are one or two top strategies that you're working on with your payers to improve that traction, that productivity?
I would say we're still early. It's a dance for certain, and I think that there's going to have to be some give and take on both sides. Coming at this from a traditionally fee-for-service mindset, I'd say there's some skepticism on the other side, and both ways. Are the payers going to really pay us to do what they say that they want us to, and to manage the patient? And we've got to prove that we're really serious about doing that. But if we do that, we believe we can shift volume, we can shift patients from other plans or other competitors into our model. So it's a bit of a dance that we're going through, but I believe it's the right thing to do. And to a certain extent, the pandemic and the staffing shortage is driving the need to innovate and do things differently from how we've done it before. So that's how we're approaching it, but I'd say still early in that journey.
All of this requires a lot of budget,
mm-hmm.
and the macroeconomic environment is very challenging. Recessionary inflation, job cuts, depressed to negative margins for providers. Yeah. How are you balancing the budget prioritization between running the business and innovating and changing the business?
Yeah, it's a delicate balance, as you said. We did end up, last year in a profitable situation, but our cash flow and profitability was not as high as we would have liked it to be. And then that really fuels our ability to be innovative. So we have carved out dollars. Our board is very supportive, and our owners are very supportive of us having a long-term view. We know ultimately to do this business right, we're going to have to change the way in which we've always done it, that historic status quo. And so we have prioritized dollars in our capital budget and in our operating budget around innovation, but it's not innovation for innovation's sake. It's really innovation that's going to advance our strategic mission. And so as we think about how do we digitally engage consumers on the front end, how do we have smarter facilities where we can provide better care, better efficiency to our patients, better efficiency of process for our caregivers to make good decisions, to automate some of the tasks that they're doing, not to eliminate nurses, but really to help them work at the top of their license and give them actionable insights, and then use technology to follow those patients home and then ultimately back into the clinic environment, sort of completing that value-based care loop. And so we've partnered with a number of different innovative companies that are helping us advance that strategic mission. And there is a budget requirement that goes with that, obviously, but we believe that this is going to advance our strategic mission of really putting the patient, the consumer, the person at the center of everything we're doing, and building a system around them where the bricks and mortar of the facilities is just one aspect of the care we deliver.
Examples of some of this innovation at scale that's live?
Yes. So we've partnered with a company called BioIntelliSense. They make what they call a bio button. It's a small patch that's about the size of a silver dollar that sits on your chest. And that patch can automate the vital sign capture for a patient. And so when we think about advancing, smarter facility care and making things easier for our nurses, that patch is able to automatically capture vital signs. But we're able to capture ICU level metrics in a med-surg floor. And so instead of taking vital signs 4, 5, 6 times a day, which is the typical frequency, we can get ICU level monitoring. Now the computers can analyze that, detect somebody's improving better than we thought or deteriorating, and we can respond appropriately. Can we get that patient out of the hospital onto the next level of care, or do they need to be moved into a more intensive care situation? That same patch, we've partnered with a company called Cadence, and they do remote patient monitoring. So now that patch that was with the patient can go home with the patient, and we can see how are you doing once you've been discharged. If you're improving, great. If you're deteriorating, we can intervene and hopefully prevent that readmission. That company then feeds into a company called Care Harmony that we've launched, and they're focusing on chronic care condition management, social determinants of health. And so all of these things start to work together to create this value loop, and again, puts the patient and their condition at the center of what we're doing, and realizing at different points of the life cycle, they're going to interact with different parts of healthcare, but we're focusing on them holistically versus just episodically in an acute environment. And then from an innovation within, we've also partnered with SwitchPoint, which is a local venture studio that's focused on AI-based solutions to bring a different way of doing things in healthcare to the forefront, and creating innovation from within and building and scaling our own companies from those efforts.
Let's talk about leadership.
Yep.
In life, business, career, there are rules, norms, codes on how things are done. Where have you been a code breaker, and how did you do it?
I feel like I've never really fully adopted the code. Now, I believe that within the ethical and moral boundaries of the law and the business that we run, everything else is white space. And all too often you see people sort of following the pack. And I would say, this is something I say with my family, are we sheep or are we wolves? And we're going to be wolves. We're going to chart our own course. And we're really going to drive our priorities, our strategies. And again, we're going to stay within the boundaries of our industry and the ethical and legal norms that we have to. But inside of that, everything else is changeable. And so for us, that means really putting the consumer at the center of what we do and not ourselves. Changing this industry mantra of the field of dreams, if we build it, you will come. And for the longest time, patients did, because that was the only thing they can do. Now what we're really trying to do is be the trust broker, realizing we're not going to be all things to all people, but how do we as health systems put ourselves in the center of being that trust broker, integrating with the patient, anticipating their needs, delivering on those needs, and doing things the way things ought to be done versus the way we've always done it before.
Marty, thank you so much for joining us.
So glad to be here. Thanks so much for having me.